It's really nice to see you all Sunday morning at 8 o'clock for this lecture. It's very encouraging. And it's an amazing two-day program that SPIK has organized, and there's a big organizing team behind. But I would like to profusely thank Dr. Jose Paul and Dr. Biniraj. Sir was like, I was seeing the group. I see the group often, and all the messages that keep coming in. He's so active in organizing this entire show and making sure that everyone gets something from this conference. And I'm sure that with the hands-on and with the lectures, there are many who have learned so much. From my lecture, I just hope, like I was telling sir, I just hope that everyone gets a couple of takeaways. These are things maybe all of you know, or maybe some of you also do. So, but for the rest, it'll be something new. So you've been having a lot of clinical lectures, a lot of clinical videos and lectures and all of that. I'm going to be taking a laboratory perspective on things, what usually happens in the lab with regards to digital dentistry. So digitalization in implant dentistry, since this conference is all about implants. Okay, so speaking of lab perspective, some lag here. Okay, so I come from DenCare, and for those of you who have not visited, please do come and visit us. You're always welcome. This is our manufacturing facility. This is our corporate office, and we have a global presence in the US. We have 3 entities in the US and all over. A lot of certifications that we work on. So these certifications are because dental processes are now considered as a medical device. So we need a lot of certifications for that, and that is the latest certification that we have of CDSCO. And yeah. We have workplace, occupational health and safety, environmental safety. We do a lot of sewage treatment, and we work a lot towards, trying to give the best quality with the best materials that are available in the world. So it's a big operation that goes far. I'm not just going into the journey thus far, the journey that began in 1988, but working on implants started very early. Working on zirconia started very early. Am I audible? It's okay. Yeah, and some of the highlights are, direct metal laser sintering, which is now a very key driver for not only general dentistry, but also implantology, and 3D printing, definitely, and digital impressions, intraoral scanners. So these are the giant leaps in dental technology, right? Our team has also developed a 3D printer. It's a DLP printer, so with which you can print anything that you want with the materials available. You can customize the printer to print any other manufacturer's resins also. So it's a high-speed printer, and it's all possible because we try to optimize the workflow in the lab. So we've been doing a lot of 3D printing for many, many years. So we thought, why don't we develop something that is more economical, yet, great on quality. So coming to the implant market, we see that, the forecast is huge, right? In fact, that's why this conference is there. It's all about implants. So initially, the older practitioners, older clinicians, they know that it was all PFMs, right? There was no zirconia. So then an evolution came into zirconia, and now we have, there are many pros and cons, but still zirconia is what is going to be, is driving a huge force today, and it's going to go into the future. Similarly, initially it was all dentures, and then we came into crown and bridge processes, and now we are moving into implants. So implants, awareness is more these days, and more people want to do it. It's not like a specialty anymore. So everyone can do implants. So the market is huge, and the scope is huge for global implantology. You have a huge number of, a lot of systems in the market, right from, titanium and ceramic implants, and a lot of things to choose from, and a lot of factors and considerations. I think a lot was discussed yesterday. And when we speak of digital dentistry now, in fact, that's why the workshop is also about scanners, but it's just that it's evolved now. It's not something really new, right? The entire conceptualization of digital dentistry was in 1983 by Dr. Francois Duret, and that's a small clip from his thesis in 1973, where he got the idea of, optical impressions, which then, materialized in 1985, where he presented, formally the idea, and he came out with the first CAD-CAM system for lab. It's called the Duret system. And then the first commercial CAD-CAM system for a clinic, right? It's not something new. It's been there for some time. And also with the first CAD-CAM software. So it is around this time that Siemens came out with, in collaboration with the University of Zurich. We had Dr. Morman and Brandestini, who was an engineer, and they came out with CEREC. So CEREC, CEREC is nothing, chair-side economical restoration of aesthetic ceramics. Okay, so that's what CEREC stands for, and that was introduced by Siemens around that time. So all of these technologies are pretty old, but they've evolved, and now it's come to a position that it's more affordable. In fact, it's as old as the RVG. So usually people think that digital imaging came first, but all of these came at almost the same time. So Dr. Francis Moe, who introduced the digital RVG system in 1987. So you are already practicing digital dentistry. It's just that digital impressions is something that, is not gone to the masses yet. So when we speak about digital implantology or digitalization, so the first thing that you need is data sets. Will this work? Huh? This won't work. Okay. Battery, We begin by acquiring data. So to work digitally, you need data, and the most common data that you need for implant planning and implant surgery are DICOM files. Okay. So we have DICOM files, and we need an STL. So the STL is basically a digital file for a stereolithographic format, which we use in the digital form. So you can digitize analog impressions, you can pour models and digitize them into these STL files. So you have a DICOM file and an STL file, and these are the basic necessities for implant planning, right? So in order to do a guided surgery, you had in-depth discussions and lectures on guided surgery. You had a workshop. So I'm just going through just the requirements. You have a CBCT, and you need to have a cast, you need to have an intraoral scan or a physical impression. And you need to decide, okay, what system you're going to use. The system you're going to use needs to have a guided surgery kit, right? And what kind of guide are you going to do? You're going to do a fully guided or a partially guided. And definitely, if you're going to do a fully edentulous case, you need to have a denture, right? So just by taking CBCT without a denture is not going to help. I think it's fine. It's fine. So. Okay. Yeah. So you need to have a denture if you want to do a fully edentulous case. So the patient, either you make a denture or use the patient's existing denture. So you reline the denture for best fit, and then you take a dual scan. So you take a CBCT of the denture in the patient's mouth, and you take a CBCT of the denture. And we align these data sets. So it's generally termed as a scan appliance. We call it a scan appliance because we're using it to scan. So we can use gutta perca markers, glass beads. Otherwise you get, I don't think you get it in India, but you get certain markers where you can just apply directly onto the denture. Or you can also do something like, you can use the impression tray as a scan appliance where you scan the tray and then the impression in the patient's mouth. So basically you need data sets. So these are the most primary, information that you need. You need a CBCT and you need an STL file, which can be digitized or otherwise. So since we're talking about digital, it's going to be STL. So additional data. Now all of these things are not very common. It's slowly coming in. Additional data, if you want to improve aesthetics, is by getting a face scan, and you can have jaw motion tracking too, right? Because if you want to replicate, now how can we replicate the mandibular movements and all of that in a normal way, right? We need to take records, we need to program the articulator, and we need to work on that. So that's how we can do it. That's how we do it the analog way. But if you have to do it the digital way, you need to have certain sensors and certain devices which will track your jaw motion. So this is the face scan. There are different companies that come out with face scan. You have handheld scanners, you have desktop scanners, so where the patient's face is scanned and you get a file with which you can merge into the CBCT, into your STL, and you create a digital patient. So there are many companies or many equipment that help to track jaw motion. So you have something called SDI Matrix, Zebras, and the latest Mod Jaw, right? So all of these, they have sensors here and they have cameras, and basically the patient's motion of the jaw is recorded, and that information is again exported into the design software. So all your values, right, your Bennett's, your condylar, everything can be incorporated into the design software. So these are additional data, okay, which you can use. So there's some CBCTs that, help in this jaw motion tracking also. So basically, you will have a CBCT, you have an STL, and you will have a facial scan, and you can have a digital face bow also, and you merge all of that into your planning softwares. So there are different softwares that you can use to plan. Sometimes you need to use multiple softwares to plan, so you can use any number of softwares and plan your case. Right, so all of these data are going to come into, exported into or imported into this software, exported from various sources and imported here, and all of these are merged into one. So that's what happens. So I would like to really thank Dr. Nitish, who's really trained us in stackable surgical guides. What we're going to see next, and I'm really proud to say he's a periodontist, right? And he was in Chennai for many years, and then in New Zealand, and now he travels all over the world. So we're going to go to the first case. I'm going to call it Mr. Dummy because it's going to be, these are all dummies. So we're not going to see an actual, patient case. Definitely I have some articles on that. But as I told you, it's just going to be a laboratory perspective for you to basically and very simply understand what happens in a fully digital workflow. So here we've taken two data. We've taken a CBCT and we've taken an STL, okay? And we import it into a CAD software. The software we use for this case is ExoCAD, and it goes through a series of steps. So first you have to, define the panoramic curve. Then you need to merge data into that. So we have merged the STL and the CBCT. All right. And then we design the prosthesis first. Okay. So always prosthetically driven planning is what has to be followed, whether you're going to do it the analog way, freehand surgery. It's not that many people do guided. Majority of people do freehand. So even when we do freehand, the aim is to think about where your prosthesis is going to come, and that saves a lot of time for you and for the laboratory, and you can definitely have a clinical outcome. So Dr. Lina will be speaking about prosthodontic workflows in the analog scenario, and so she's going to, explain on some challenges. So first, the prosthetic aspect is designed, and then the implant planning is done. So we're going to get a good prosthetic outcome. So in case it is a laboratory that is doing it, laboratories also have periodontists and consultants who plan or who analyze the plan. It is then discussed with the clinician, okay? Or if you're going to do it, that's well and good. But if you're going to give it to someone else, you need to communicate, right? And as Dr. Kristen Cochin said, we very recently in Morocco for the Digital Dentistry Congress, he was focusing on asynchronous communication. What he said is, gone are the times where we are going, where people speak to the technician over the phone. So it's all going to be asynchronous. So people work all across the globe, and they, synchronize by some kind of messaging application like WhatsApp, where they, discuss terminologies and, discuss the case and discuss what outcomes are there. So after the plan is finalized, all the iterations are made, it goes into the further planning of the guide. We need anchor pins to stabilize the guide. So this is going to be, what we are showing here is a multi-stack guide, or it's called a stackable, multi-level guide, or it's called a stackable guide. So first there is a base guide for bone reduction. Then you have a positioning guide to place the guide. You have a bone reduction guide. You have a drill guide, and you have temporaries on top. So the patient leaves the clinic, or the patient leaves you with temporaries in the patient's mouth. So this is a completely planned case. So after the planning is done, the guide designing happens, the drill holes are made, you have a guide, and stacking is done with various softwares. Okay, there's no single software to do the stacking, so we do it in a couple of softwares, and we get a stack like this. We design a stack like this. So we have first on top the positioning guide, down is the base guide, okay, which also acts as a bone reduction guide. Why do we need a bone reduction? Okay, we want, in case it's not indicated in all cases, but all right, if you have a very thin ridge and if the bone is uneven, you want to flatten it out for, better placement. So then what we do is we're going to, okay, this is a 3D printer which we recently developed, and we've come up with many iterations of it. So what we do next is we can either print them in resin or print the base guides and the drill guide in metal. Okay, so can you have the audio, please? Yeah. Those. Yeah. So these are all DLP printers. Okay, we have different tech processes for printing. We have SLA, DLP, and LCD. So this is a DLP printer. Maybe during the hands-on, I can iterate about different types of printers. So what happens here is the design that was done is then nested for printing. So while printing, you need to give supports for printing. So whether it is metal or whether it is resin. So all of that is done at this stage, and the process is called nesting and splicing. So every layer is printed. So you need to splice the existing data into different layers and feed it to the printer to begin printing. So again, you set the data, select the file, and it goes into print. So the difference with printing over milling, so in printing you can print a whole bunch of things in one tray, right? But when you do a milling, you can only do it in one plane. Recently, a person asked me, can you stack multiple levels when we do milling? So it's not possible. So if you're doing a little bit also, the material will go if the excess is there. So you can't have milling tools coming in between. But in printing that is possible, you can position it in any way. So after printing, we can remove these supports, all right, and then we need to wash it. You can use IPA. We use IPA to wash. Okay, what happened there? So we use IPA to wash, and then we do a post-curing. So we do a post-curing in UV, and after that, you're good to go. So this is what we come out with. Now again, as I told you, this is a dummy. Okay, we printed the jaw just for you to see. Okay, so you have the base guide over there, and you have a positioning guide. So using the positioning guide, we position the base guide onto the bone. Okay, so the patient has a few teeth out there. So after this, the extraction is done. Okay, and post extraction, you see the level of the base guide, and bone reduction is done to that level. And after that, the drill guide is placed on to the base guide. So these two can be in resin or metal. Okay, so metal is a little even better, but again, it's a little more expensive. And after that, the temporaries or the prosthesis that you designed sits on again to the base guide, and after the implants are placed, all you have to do is to pick this temporary prosthesis, right, in bisaccharide or any material, and finally deliver the temporaries to the patient. So that's how stackable goes. So, but it involves a lot of planning. So you need to start with the prosthesis, and then you can deliver the temporaries, and the patient leaves the clinic with teeth in the mouth. Right, so we can do direct metal laser sintering, and you can have these base guides, and titanium is the ideal material to have these guides, but you can do it in cobalt chromium also. So again, after 3D printing, this is what you come with. You see the supports. So this is for any type of printing, crown and bridges or implants, and you have these supports, and after your 3D print, you need to sinter it. So all of this takes time. For example, if you do a huge a print like this, it's going to take 4 hours. And then if you want to sinter it, we do a post-sintering, and that also takes another 4 hours. So these are time-consuming procedures, whereas printing is much faster. This is what you come out with. So in simple terms, just for you to see what happens in a patient is, you got a patient, you can take a face scan, you take the CBCT, that's the volumetric reconstruction. You can take photographs, and you merge all of that. Right, and you merge all of the data here, and this is the digital avatar I was talking about. You have your CBCT, your STL, and the facial scan, and the photographs all merged. And based on that, you can do a mock-up also if you want. If you have a face scan, you can do a mock-up. And based on that, you can design the prosthesis, go for the planning, and you have your base guide, and you have your drill guide, and with the temporary already ready. So everything is ready before you start surgery, and then you go into surgery, place this, reduce the bone if required, and go for the drill guide and temporize. Okay, so this is what happens, and patient leaves immediately with teeth. So in this case, it was an upper denture and a lower fixed prosthesis. So we gave temporaries, right? Now the patient left with temporaries. Now patient is coming back for permanent. So that's what Mr. Dummy is back for, his definitive prosthesis. So what happens then? So you have your multi-units, you remove the temporaries, okay? And you do a scan. You do an intraoral scan of the gingival surface with the multi-units on, okay, and then you place something called scan bodies. Okay, we'll be talking about that in a little while. So you have scan bodies which record, instead of your open tray and closed tray, you have scan bodies to digitally record, what's actually there in the patient's mouth. So you do an intraoral scan, and then you have your scan with scan bodies. Your first was your gingival scan, and then you have your scan body scan, and then you have your antagonist. So you do that in the first set of scans, right? And some additional data. Now we've already designed your provisional, right? You've given the provisional, you've equilibrated the provisional, right? You might have made some changes in the provisional if required for your occlusion, and that's always there. And your tissue surface, you also need to record your tissue surface. So which is why we already have the gingival level scan for that, and then we take a scan of the temporary also along with the bite. Okay, so these are the scans that happen in digital, right? So this is when the patient comes for your final processes. Otherwise, there are certain companies that, that don't require all of this, or certain workflows where what you can do is just reline the temporary and attach specialized scan bodies onto the provisional or the temporary.
Scan the opposing teeth.
So instead of 2 sets of scans, we can do this in 1 scan. So we scan the opposing teeth, and we're going to reline the provisional bridge that is there in the patient's mouth.
The inner surface of the provisional bridge is relined with rubber.
And you use your polyvinyl siloxane in light body consistency and do a reline.
Attach the provisional bridge in the mouth to reproduce the gingiva. Remove the rubber material from the mouth when it has hardened.
So once it is set, we add scan bodies onto the provisional bridge instead of the patient's mouth. So this is another workflow, right? So you add these scan bodies onto the provisional and you can scan the provisional. So there's no need of taking the other set of scans. So this is also another workflow of digital.
The upper part is matte processed.
So the advantage is you already have your provisional bridge. You just need to scan the tissue surface and you're good to go. You can go for final processes. So all of this will happen only if you have planned first, given that provisional at the time of placement in the planned way. Okay, so you do an intraoral scan. So that's it. So let's take the case what we saw. So we've done the tissue level scan, we've done scan with scan bodies, okay. Then we've scanned the provisional also and the bite, and we upload all of these scans into our design software. So this is what we get the bite with the scan bodies. And next what we do is, we do something called matching, all right. What is this matching and how it is done? So basically, in scan bodies, they have a scan region. So these are the scan regions of the scan body. Okay, so these are multi-unit scan bodies. So now there is a different scan body for multi-unit and there is a different scan body for implant level impressions. Okay, so we need to match this with the file in the library. So each scan body has a library in design software. Okay, so these libraries and this scan body are matched. Okay, so this is a challenge when we do full arches digitally with scanners. So we need to make sure that the scanning is accurate enough and the scan bodies are used, or different materials for scan bodies, will be seeing that. We are able to scan continuously and without errors to get a good match. So if we don't get a good match, what is going to happen? The prosthesis is not going to seat. Okay. So again, matching is done, and we are going to use the file of the provisional, right? The scan provisional that we have, and we're going to design the final bridge based on that. So all of this is really fast if you've done everything pre. That is, if you've done already a planning, you've given a provisional based on the plan, and you're going for the final, then things happen fast. So otherwise things are going to take time. Okay, so you designed the prosthesis, and then you're going to mill the prosthesis in zirconia. Okay, now what we're going to show is a full arch zirconia bridge which is stained. Okay, so now milling something like this is going to take a lot of time. Okay, many hours, and to sinter this, all of these materials, zirconia, after milling, milling is done in the soft stage. It's called the green stage, and after that you need to sinter it. Now to sinter a full arch zirconia bridge, it's going to take nearly 13 hours. So post all of that, you can do a characterization in composite, or you want to do, in ceramics, you can do that. And you're going to deliver the bridge. Okay, so that's pretty much it. It's pretty straightforward. Okay. Again, we'd be checking for occlusion. Again, occlusion is the most important aspect for implant restorations, right? Most cases fail due to occlusion, right? So we need to make sure that, if there are cantilevers, we're giving enough relief. Okay, we need to give a shim stock clearance in centric and in excursion. There should not be any contact on the cantilevers, simultaneous bilateral contact. So all of these I'm speaking for is full arch. Okay, and there are different scenarios, whether you do metal acrylic, hybrid dentures, or monolithic zirconia against natural dentition, against each other. So there are different criteria for that. So what the most important thing is, there is a little bit of freedom in centric. Okay, plus we don't want excursive interferences. Okay, that's a big no-no, and that's going to lead to a failure of the restoration and failure of the implant also. So occlusion is one of the key things, which is why you need to use calibrated articulating papers of certain microns to check. For example, you have articulating foils of different microns. You have 8 microns up to 13 microns, and then you have progressive papers where you can use a 100 micron paper and then follow it with a foil to check. Basically, for implant crowns, how do we check implant crowns? Now, in a normal bite, when the patient actually normally bites, the foil is supposed to come through. But the natural teeth, the foil is not supposed to come through. Okay, there's supposed to be a tug back. And once you actually bite for the implant crown, there must be a tug back, and for the natural teeth, the foil must not come through. So you need to use all of these things to make sure that your final occlusion is fine, because otherwise all the efforts that you have spent on planning the case, placing the implant and restoring it is gone. So I'm focusing on this because this is the most critical aspect of implant dentistry, which many people fail to focus on, or many people fail to, tend to overlook. Since our topic is digitalization, now we have digital tools to check occlusion. These things most of you would have heard of. Okay, we have a tool called OccluSense. OccluSense is by a company called Bausch, okay, the leading company for articulating papers in the world, and where you can see the pressure also. So this is useful for your full arches, even your crown and bridges, where you can actually see which levels have greater pressure and greater forces, where you can equilibrate these forces. Okay, this is a little more economical when you compare it with your T-scan, but your T-scan, the difference is you get pressure and you also get your disclusion time, but it's a lot more expensive. And here again you can see where there is too much of pressure, and you can relieve those areas. So all of these will ensure that your patient doesn't come back with a fractured ceramic or a fractured framework. So the same thing, a dummy too, the same thing can be done for single restorations also. So we do a planning, we can plan the prosthesis, place a titanium base, and plan the crown, and immediately using a guide we can place the implant and also give the crown at the same visit. So these are possible not only for full arches but also for single implants. Okay, so this is what we saw as guided. Okay, and what we're going to see now is the standard digital workflow. That is, majority of people place implants freehand, right? After freehand, they're going to take intraoral scans. Okay, so this is that digital workflow I'm speaking about. We've not done any pre-planning. So this, when the patient, after your placement is done and your healing is done, your patient is coming for the prosthesis and you're doing the scan. So in that case, the first scan is going to be the gingival level scan. And the second scan is going to be the scan with your scan bodies. Okay, and the scan bodies need to be matched for the best fit. So each scan body has a scan region and we will match it in the library. So the longer the scan body, the more critical it is. Long scan bodies are more trickier to scan, otherwise you can face, some kind of a distortion there. And you need to match each scan body along with the library. So after matching all of that, what we do is we need to print models. So like we have, your lab analogs, we have digital analogs which go into digital models and they're screwed in or glued into models. So the next step is going to be printing. Okay, so after we print them, we're going to, wash them in IPA, do a UV cure, and you have your digital analogs which are going to be inserted into the model. Again, this is a tricky part, must be done really carefully, otherwise you're going to face a problem. So, and then we have cylinders, temporary cylinders which we incorporate and then fabricate a jig. Okay. Now, the question is, why is a jig required if you're going digital? So aren't we going analog again? So the question is, digital implant impressions, do they match up? And as I told you before, it takes a certain skill and acumen and a good scanner to accurately get the impression, especially for full arches. So full arches is where the challenge is. And all of these scanners either use triangulation. So triangulation is where you have a projector and you have a light source and cameras. So based on 2 points of view, okay, the 3D geometry of the object is analyzed. We also have something called confocal laser microscopy or confocal microscopy. So that's a different type of technology where, focused and defocused images are analyzed to get the image or the 3D geometry of the object. So both are different kinds of technologies, but in simple terms, it is all stitched. Images are stitched. And when we do full arch implant impressions, it is critical to, that the stitching is accurate. You don't want to go back and forth. You don't want to scan in different layers because all of that is going to reduce the accuracy. It is perfectly okay if you're doing a cemented prosthesis. The challenge comes if it's a screw retained prosthesis. Right, so you have a plethora of scanners. Okay, this is our scanner. We've got a demonstration, and the scanners are available for you to try. So it's made of aviation alloy, and we have two models. It's called Pro and the Plus. So it's lighter than the new iPhones, your 14 and 15, and we've got two models, and both of them are actually pretty small, very handy to use, and you get a good high field of view and a good depth, motion sensing, AI. So we're going to speak a lot about AI, and there's a lot of work happening in AI in the digital scene, right from diagnosis. Okay, I don't know in future whether dentists will actually be required, because AI diagnosis is already happening, and you have softwares that will tell you, will point out the diagnosis that you missed. Periodontal pathologies can be diagnosed, everything is diagnosed, and the software tells you, okay, this problem is there, so you only need to verify, okay, is the problem there? And what they say, it helps treat more. Otherwise, you tend to overlook a lot of things. I think that's the most common thing that happens, right? When patients come in, we only focus on the chief complaint, and we miss out so many other problems that would be there. So this is developing at a very fast rate. Many softwares giving a trial version. The software is like DiagnoCat. I'll be speaking about that. You can try it. So, and for general dentistry, undercuts, clearance, you can compare scans, and all of that is possible. Okay, you get 3D preview, updates free, there's no subscription, and you can upload the project file directly into exocad. So I think we will do that demonstration aspect at the last, so that we can finish, we can have continuity to the talk. So the main scans are, you have a gingival level scan, you have a scan body scan, and then you need to do a bite registration. So each scan body, so you can have a multi-unit level scan body or an implant level scan body, and each scan body has a critical scan region. So we need to make sure that the entire scan body has to be recorded, but this area is most critical. So a lot of studies on the different types of scan bodies have been done, and I don't know, it's controversial, I feel. Some say PEEK is good. PEEK is good for, they say PEEK is a little more accurate than titanium, but PEEK is also prone to deformation when compared to metal. So again, that's the challenge there. So implant angulations affected significantly linear deviation. So basically, that is the challenge with digital. So if your implants are angulated, if you're not scanning it the right way, if the scanner is not able to do it properly, you're going to face a problem, because there is going to be a linear deviation. So if you look at that, there is a difference. So that is something that can happen when we do implant impressions digitally. So all of this is mainly for full arches. Screw retained full arches is what I'm talking about. And the angular deviation that is there can affect the overall fit of the implant. So when not done, you see most of the area is not matched. There's very few area that is matched. And when that happens, the technician will not be able to work, because even if the prosthesis comes, it's not going to fit. Right? So here also there's hardly any matching. And look at the deviation. So it's not that digital is a magic tool. Digital has to be used the right way. If you're going to, and everything has a learning curve. It's not that you buy it and you just start off. So you need to have that patience, something that most of us don't have, me too. So you can see all of these scans, there are deviations, right? So what is the solution? Initially, the question was, do we need a jig trial for digital? Yes, to verify all of this is okay, we at least need a jig trial for normal people, and that can be definitely pattern resin would do. It's good enough. It's a material that's been around, and you've had your analog, you've seen the jigs already, so they are made with pattern resin. So again, the challenge is, or ideally it is best to wait for 24 hours so to avoid all that polymerization shrinkage, and then go for the jig trial. You have certain strategies that have been proposed. Things people are experimenting with to make sure your stitching is okay, the stitching of each image. So they've splinted the scan bodies with pattern resin, or you have an index. Now, this I don't think is very practical, but again, you have a digital analog combined step where you have a custom tray in metal just for those scan bodies, and you pick the position of the scan bodies. Or you have newer things, like this is a newer scan body design which is proposed. Okay, the difference is they have a library for each physical scan body that is produced. So usually, if you have, for example, Ostem, you have Ostem scan bodies. So Ostem scan bodies, even 100 in a batch, all the 100 have the same library in the design software. But people are experimenting with new things. So this new design, they say, is by a company called Nexus. So what they have is, for each scan body they fabricate, they make a separate library for that physical scan body. So, and if you see how these scan bodies are aligned, you get a more continuity when we go from one end to another. Okay, so this lecture is, I don't know, many of you would have seen all of this, but this might be new to some. This is just to show you what all is happening in the digital scene in implant dentistry. You have some scan bodies with bidirectional pins. So the bidirectional pins are in peak and they provide a continuity when we scan edentulous full arch. Okay, so what is the ultimate at present for implant impressions, full arch? You have something called photogrammetry, okay? You have cameras where you record the implant positions at one particular time itself. So the position of all these implants are recorded at the same time. There is no stitching from one end to another like we do for scanning. So you have these flags and you have cameras and they record these positions relative to each other. So it's more accurate. It's not that it is completely, void of any deviations, but it's more accurate when we compare it to the normal digital scan bodies. So this is only to record the implant position. You also need the scan also of the soft tissue. So you just can't have this. Someone had a doubt, if I just have this, I don't need anything else. I don't need any bite, I don't need anything, I just use this. No, it's not like that. This is just to register what position the implant is in. And you have different iterations. You have the iCam, you have something called a handheld. You have a handheld called a micron mapper, and they have their scan bodies. So a lot of studies have shown that, iOS had mean linear deviation of 2 to 185. So, which means that it can either be really accurate or it can go wrong. But for photogrammetry, that is PG, is 70 microns. So it's a little more standardized with photogrammetry. A lot of studies is feasible. So in clinical oral implants research, they have said that must be again used with caution. So rigid prototype trying, again either using a jig or a prototype of the teeth is required before screw retain prosthesis. So till now what we saw was impressions, right? Now we've got the impressions digitally, and after digital impressions we need to take the bite. So this is a normal workflow. Patient has implants, we have done impressions, and now we need to take a bite. So for that we have something called, we fabricate a bite trim over a few abutments which you can use to do the jaw relation. So Dr. Lina will be speaking about all of that in the afternoon, so I'm not going to go much deeper into that. We do the JR, and then after that comes the teeth setting. So we do the teeth setting and we again try it in the patient's mouth, make any adjustments that are there, right? And after this is finalized is what, the actual different prosthetic outcomes. This is normally how it goes, but actually you're supposed to plan all of this initially. What are we going to give the patient? So are we going to give a full fixed bridge, or we're going to go for a hybrid metal over acrylic, acrylic over metal, or are we going to go for an overdenture? Again, it depends on the intra-arch space or the intra-arch distance. This is an important aspect. So from where are we measuring? So depends on that and how much of space is there. So if there's a lot of space, you can't give a fixed, more than 18 mm. If you go for a fixed bridge, it's going to be too huge and too heavy. So you need to go for an overdenture. So we have the teeth setting trial that has been approved, and then that's scanned and the lab scanner uploaded. So you have these virtual articulators. Okay, so if you have these jaw motion, you get these values for this. Otherwise, you need to print them and take manual records if you want to go to that level. It helps to reduce chairside time and adjustments. Otherwise, definitely you need to do chairside adjustments for occlusion. And after that, we have a resin prototype. Okay, so we give a resin prototype. Now this is characterized, usually not like this. It's a clear template can be given. And after the patient and the clinician, after you okay the resin prototype, we move in to fabricate the definitive prosthesis. So again, when we do trials, in fact, after we place the scan body itself, we need to first verify with a radiograph whether it is fitting properly. Same as when we do with impressions, your open tray and closed tray. And each part of the process, when we do a jig trial, we need to verify. Okay, sometimes you feel that it is seated well, but it is not, and then the entire process has to be remade. So then we move on to make the final processes, and when we go, so now these are frameworks for something called a thimble design or a malo bridge, a combination bridge. So basically you have a framework which can be in different materials, and you have individual crowns. So that's what this slide is. So we have done it in cobalt chromium, this is titanium, and this is something called PEEK. So for PEEK, we have modified PEEK, it's called bio-HPP, and it's really a lightweight material when that is required or the case demands it. So what are the different material options that you can do? You can go for a zirconia fixed bridge, a DMLS fixed bridge. You can go for PEEK or bio-HPP, veneered with light cure composites. We can, sinter titanium. So I love this. I love titanium because it's lightweight when you compare it with cobalt chromium, and titanium layered with composites, there is nothing like it. So you can sinter or mill. So there is two options. You can either mill the titanium or you can do laser sintering. And hybrid processes. So basically this is the metal framework with acrylic on top. Okay, sorry for that. So the frameworks can be either in cobalt chromium sintered, you can sinter it in titanium, okay, you can mill it in titanium. So a lot of prosthetic options that you can choose. You can do it in PEEK, and you can have what we call as the combination bridge or framework to receive crown and bridge, in most simple terms. So you have a framework and individual crowns go in there. So you need space for all of this. So usually what happens is, you can't, unless you plan it properly, you can't commit to the patient, okay, that you're going to give something, you're either going to give this or you're going to give an overdenture. So you need to analyze the space, and that's where the planning is very imperative. So you can give this combination design in zirconia too. You can do it in bio-HPP. And then you have your overdentures, you have your bar and clip, and you have your telescopics, and you have your ball abutments, you have low profile, what is called as locator. Locator is actually a trademark of Zest, but what we use Rhine 83 attachments, Italian. So you have these low profile, it has a lesser profile than your locator, have a bar with an OT equator. So what we saw was digital workflows, we saw the fully planned guided workflow, we saw the normal standard digital workflow, and then you have something called a hybrid workflow where we go from analog to digital. So what are the preceding steps for hybrid workflow? You have your impressions, you have your jig, and you have your bite registration, teeth setting, abutment selection, and you finish your resin prototype. And following that, we digitize this with lab scanners using titanium bases and design the processes over that. Okay. So again, full arch we design and we mill. I'm taking this forward because I don't think we would have enough time otherwise. So again, so this is post milling in the green stage. Okay. So this is green stage zirconia where you can do some kind of a shade infiltration. Okay. You can do shade dipping or shade infiltration. Infiltration is done with brushes and you give. So this is full arch monolithic zirconia with just some staining. So you just infiltrate the portions that we want to, and we keep it in the furnace for sintering. Now sintering this is going to take nearly 13 hours. And after that we can characterize. So now we can characterize with composites, we can characterize with ceramic, and we get the final outcome. So what we saw was, we saw the guided workflow, we saw the standard workflow, we saw the hybrid workflow where we go from analog to digital. You can know there's also something, this is just for your information, there's something called the OT bridge. It's a fixed bridge system from Rhine 83 where you can give fixed bridges in divergent cases also. They have these elastic seegers which helps to compensate for that. You just need to keep changing these seegers maybe once they wear off, but again, you place the implants, you don't know what to do, these are another option. So this is a case where a guided surgery was done with these seegers, and you have these low profile OT equators. So something like the locators that are placed, and the prosthesis will have these kind of elastic seegers inside them. So they compensate for angulation. So what all we saw in digital today was static. Now there is something called dynamic. This is again for your information. And there are a few people in India who are doing dynamic navigation. So the patient comes to you, you can take a CBCT and immediately start planning and start placing. So again, you have a failed bridge, the bridge is removed, and you create a chairside stent. So this is the latest in digital for implant dentistry. Dynamic navigation place surgery. So the stent is customized. And you need to add fiduciary markers. The fiduciary markers help to identify. These are like your gutta perca. They are all fiduciary markers, and you need to identify them in the CBCT. So with the stent in place, the markers in place, the CT is done and planning is done, and then we go directly into placing. So the dentist doesn't look at the patient. He looks at the computer screen. So there you can see he's placing this, he's calibrating each tool. So the normal implant placement tools are all calibrated, and he's directly placing it, and the computer is going to tell whether we are, how far we are deviating, are we going in the right place. So this is the latest cutting edge technology for implant placement. So you have static guides, you have stackable guides, and then you have dynamic guides. Again, there is a steep learning curve to it. So that is dynamic navigation. So again, you need to calibrate each tool that you place, you need to calibrate the implant, and the software guides you. So you can do an all on X. So again, I'm just going to go through these. You just do the planning. You plan each implant and you fix a jaw tag. Now this is an edentulous case. If it's dentulous, you can use a stent, or you fix a jaw tag, and then you do a calibration. You trace each implant position that you want, and once you place, again you can give a restoration immediately. So all of those initial steps are avoided in dynamic navigation, and we have people in India who are doing dynamic navigation, and this is Dr. Ashwini Balarao, who's I think the board member for Digital Dentistry Society. She's published on zygomatic implants using dynamic navigation. Really tricky stuff, but it's amazing as to what technology has come to. Right? So you are looking at a computer screen and seeing where your implant is actually going. That is the accuracy. Obviously, as slight deviations may happen, everything has a tolerance, but definitely this is something new. And research is going on into robotic surgery for implant placement. So a lot of work is going into that. People are publishing on that. They have tried autonomous surgery. guiding the robot. So in some time, maybe 20 years down the line, I don't know if we'll be sitting with robots to place implants. So this is the latest version of dynamic navigation. There's a camera. So when I tried it, it's really interesting. So as you move your hand, the camera turns as you move. It tracks your motion. So it's truly dynamic. This is the latest version of this navigation system. Just for all your information, you have tracer tools. Yeah, the system is, I think, initially the earlier systems were, I think, 20 lakhs, but these systems are coming to 50 lakhs for this navigation system. And before I conclude, I want to say the future is now. As I told you, a lot of AI is there. We have a software called Missing Link. Again, all of this just for your information as to what is new and what is happening, which will diagnose a number of periodontal conditions, a lot of problems. The software tells you where the problem is, and you have other softwares. These are just two softwares I put in. There are empty number of softwares. You have softwares for designing crowns. Single crowns, the software itself will design. You just need to scan. So a lot of that is going into that space, and you have augmented reality. Now with these lenses, like you've seen with Google, Microsoft and Apple, wearing these, if you can do an intraoral scan, you don't have to look at the patient or the computer screen, because you will be able to see everything inside your goggles. So you can do virtual planning. These two people can be in the same room or in two countries, and they can actually virtually plan an implant case. Expensive now, but maybe 10 years down the line, this is going to be really affordable. So thank you so much for your patient listening, and I know it's a lot of information, but it's something new, just for all of you to understand what is happening in the digital scene for implant dentistry. I will just have a quick look regarding how we scan implants. We have a few scanners here. Anyone who wants to just come forward and try, you can. Otherwise, you can do it at the workshop. Anything is fine. I request my team to please come forward. Looks like this is an Austin scan body, and this is an implant level scan body. Focus. Okay. Okay. So this is in metal. You have scan bodies in PEEK also. And focus on. Dure pona. Yeah, thank you. So the first scan is going to be a gingival level scan, and then you're going to place these scan bodies. Okay. Now, when we place these scan bodies, it is preferable either to place the flat surface. Basically, the scan region is what we need most importantly. So you can see here there is a scanned region. So when we place that buccally, you get a little more, it's a better scan and an easier scan. And after this, you've got to screw this in, take the scan with the scan body, and then finally take the bite. So that is the basic workflow for an implant scan. Option for the scan body, and then the antagonist, and then the bite. Okay. We have different options. We have options for keeping AI on, different modes to scan resin and teeth. Okay, so first what we're going to do is we're going to do the edentulous or the gingival scan. So the first scan is going to be for the gingival scan. It's just going to be the gingival scan, and we're not going to do the scan body scan first. Okay, and which all areas, as I told you before, trying to get in the single pass for full arch is very mandatory. So now we have the edentulous scan. Okay, so you can, most of scanners these days come with this motion sensing, so you can actually rotate the scanner and see the scan. So this is for the emergence, and next we have to place the scan bodies. So then we go to the next option, and I'm going to place the scan bodies here. So after placing the scan body, you need to take an IOPA and you need to actually check whether the scan body is fitting correctly. Most critical step, you miss that, and if it's not fit properly, you're going to have a problem. So most likely what happens is the scan body, if your bone profiling is not done adequately, I'm sure that was discussed yesterday, your processes, your jig fits, everything fits, but the final process, once the abutments come in, they may not fit. So again, bone profiling is most important. So we've got our initial scan, and now we have to do the scan body scan. So to record the scan body in three-dimensional space, we need to create space depending on the angulation of the implant that is placed. So if you make a mistake in this, that's okay, you can create another hole. So we are creating space to record the scan body in a three-dimensional setting. So as you can see, the hole is completely, it's like a cylinder that has gone through and through. And then we go on to record the scan body. Okay, we have music for this, but the music is kept off. So the newer update that's coming is going to be very easy to handle implants that are very close to each other. Now, a question that is most commonly asked is, what happens if I don't have enough scan bodies? So there's a function where you can use a log function, and you can scan each scan body at a time. The newer software, we are giving a separate scan for each scan body. So you don't even have to do the log function. So things are going to be a little more easy. But it's always best to have some scan bodies with you so that you can place all of them at the same time and scan. It's very critical for full arches. This area? This one? In the tissue, this is okay. This is fine because we already recorded the tissue level in the first preliminary scan. So after this, okay, the contact, again we need to check whether we get the contact correctly. Yeah. And after this, in the next step, what you see here are holes, okay? in the lateral incisor, so that is data that was not scanned. So once we do this, we go to the next step, that is the bite. So many a times with the scan body in place, you will not be able to take the bite. The scan body will interfere with the bite. So what we do is we remove the scan body. You don't need the scan body. So we are only speaking about implants right now. So there's a lot of tips and tricks that you can do for full arch crown and bridges. You know, you can do a pre-scan. You can record the bite pre and just do a full prep. The problem that most clinicians struggle with is getting the bite registration for full arch restorations, especially once you prepared everything. So you have a lot of tips and tricks that you can do digitally. It solves the problem. Okay, so next, after this, we do a bite scan, and we have removed the scan bodies, and we're just going to do 2 bites, one on either side. Okay, so we're going to do one side. One second. Oh, we missed something. We've forgotten to scan the lower. Without the antagonist, you can't. Okay, so I'm going to quickly scan the antagonist. So initially, you need to select whether, you know, where your implants are going to be placed. If you have implants on the lower, you need to do a lower scan body scan also. And some people have a question as to what do I do for an abutment level scan, right? All of these are for implant level scans. So now if you're going to place you've selected a stock abutment and you're going to, you know, you want to take a scan of that, you can just take a normal scan of the abutment because you're going to do a cement retained restoration. If you're doing a cement retain, you don't have to do anything else. Just make a, you know, a normal crown and bridge scan and you're done. You don't need scan bodies. So you need scan bodies only when you're doing an implant level scan. So then you go for the bite. So when you take a bite, the most important thing that you need to do first or after each scan is remove excess. So this is something especially distal so that it doesn't interfere with your bite registration. And always after digital bite registration, it is always best to verify clinically whether this is the actual bite in the patient's mouth. Okay? The advantage over analog is analog, you know, you need to cut the bite, you need to remove the buccal portion. I don't know how many people do it, but you actually need to verify the bite. So digitally it's much easier. So, one second. So the upper and lower are done and we come to the bite scan. So the bite is registered on one side. You go to the other side. And it's done. So we have the bite registered and we just have to process the scan. Processing of the scan just takes a minute and then you're good to go. You can upload it into the cloud to the lab that you want to do it. If you have a chairside printing unit, you can immediately go into printing. So these are the basic steps for implantology. At implant level, we go with scan bodies. And there's a host of things that you can do for crown and bridge, and all of that you can come to the store and, you know, try your hand at it. We kept so many scanners today so that majority of you can try it. As I told you, full arches, a lot of tips and tricks that you can do, and makes it a whole lot easier when you compare it to conventional, right? In conventional, you cannot correct mistakes, but with digital, you definitely can correct mistakes, and that's a big, big plus. So we wait for the scan to be processed, and once it's processed, we just verify if everything is okay, and then we just send the scan to the lab. So that's about digital for implants, and if you have any questions, you can ask. Feel free to, we're here today, and you can ask us. Many people think that these scanners are like a magic wand, okay? But there are things that you need to, there are a lot of mistakes that can happen with digital scanning also. So there is a learning curve to it. Even if you get a scanner, please don't expect to, race away initially. So a lot of factors, a lot of things that you need to keep in mind. You need to do retraction where required. Like you do for your physical, you need to, for your digital also, you need to do retraction when it's required and make sure that the field is very clear. So other than that, for digital, the only drawback now is for complete dentures. Complete dentures, you can do the preliminary scan for complete dentures, but border molding, you would have to do that. Okay, so that is the. Oh, we've gone. We've got our scan bodies, we've got our upper and lower, and we've got our bite all aligned, and we can export and share and just send it to the lab. If you have design software in your system, this is compatible with ExoCAD. So if you have a license of ExoCAD, you can open this file directly in ExoCAD and begin to work. Now, design softwares also have different modules. So there are modules for creating models, there are modules for spinal design, there are modules for implant planning. So each module is different. So but the scanner is fully compatible with ExoCAD. So some other features that are there, okay, now this is, okay, I'll probably do a crown and bridge and then I can just show you some more of the features that are there. So let me create a new case. Okay, a pre-preparation you can. Okay. So before you begin your preps, you can do a pre-scan and you can do the full arch scan if you want to. So you have your upper jaw and you can do an initial scan, pre-prep. So most of these technologies are available with the scanners that are there right now, but where the difference is how much of R&D has gone into it and how much of support that you get. So that's basically going to be the preliminary difference that is going to be there. So you can do a pre-preparation scan. Okay, and you can automatically do a clean. You can remove any excess data that is there. So you can take photographs during scanning if you want to. You can see it in black and white, so that's also available as a toggle, right? Okay, so areas in the sense when basically even if you make a mistake, you can correct it. So you're not getting areas, critical areas to be scanned. You need to scan the preparation surface. You need to make sure, the most critical thing is before we scan to make sure that you have sufficient, restorative space, that your prep does not have undercuts. You can use this to detect undercuts. We can detect undercuts with the software on the screen. But the sad part is many clinicians don't do that. Even with scanners, they just scan and just send the file across. So they don't actually fully use the functionalities of the scanner. So you can actually measure how much of undercuts are there for full arch cases. So when you do full arch, that's the challenge. A lot of people are into doing full arches now. So when you do prep a full arch to get it without undercuts, it's a big challenge. So if you need to reduce undercuts, you need to know where to reduce undercuts. So you can use this to scan and actually measure where your undercuts are and where you can mark them and reduce them, and it makes, it saves a lot of time because then the technician directly can start working. So the main thing is the scan strategy. The scan strategy, there are many scan strategies. The easiest thing to do is the occlusal surface and then your palatal lingual surface. When you do the occlusal, and when we come to the incisal edges of the anteriors, we can, go front and back and then do the entire occlusal surface, the palatal or the lingual, and then the buccal. Yes. Okay, so for a scanner, you will need a laptop. So that is going to be the main two accessories that you need. Okay, now different scanners have different compatibilities, but what we recommend is a minimum of 16 GB RAM, but 32 GB RAM is always recommended. Why it's recommended to go a little higher is a lot of updates keep happening. So what we've seen is many people buy a laptop and maybe after a couple of years, they feel that things are slowing down. So that's because that happens with all our gadgets. Now we change our phones, right? We change our laptops if we are using it for certain purposes. Now for general PowerPoint use, we don't need specs, but with each upgrade, the software gets heavy, and we need to keep some memory for that. So what we've recommended is 32 GB RAM, and we need a minimum of 6 GB of graphics. So if you have an existing laptop, you need to see whether you have a graphics card, because most laptops don't have a graphics card, and you need an i7 processor at least, Intel i7 processor. The scanners, our scanner we don't recommend AMD, but scanners have run on AMD, but Intel is what is recommended. Intel i7 processor with 32 GB RAM, 6 GB of graphics, and storage space. So this is the main requirements that you need. You need the scanner and you need the laptop, and that's it. So there are two types of scanners. Now one version has a power adapter, one version is plug and play. So this is the plug and play version. It's pretty sleek. It's just this much. And scanners come in different prices. Now our scanners are priced at, I think the present pricing is, Ablash, what is the present pricing of the scanner? Present pricing. Okay, 6 lakhs for the Plus and 8 lakhs for this plug and play Define Pro. So you get different scanners, you get ultra low cost scanners also. But why we've selected this is because we've tested a lot of scanners, and we felt that this is the right one for the masses. Yes, there is a 3-year warranty. It's a replacement warranty in the sense if you face a problem, we've immediately replaced the scanner with another scanner and see what the issue is. So that is the main criteria when we talk about scanning. So the support or any equipment for that matter. Training, yes, while installation there is a training, and definitely if you need any support, we're always there to help. So that's always going to be there. Any equipment that you buy, you need to have the service for that, so that's going to be a key factor. There are other, there are good scanners also. You have your Prime scanner, expensive, but really good scanners. So again, depends on what is your budget and what are you looking for. Right? So we went with this. This is developed with a company called Frekete, and we've done a few customizations for us. At least we've done it jointly. We've given inputs from our side, and they've implemented for their line also. So, and we're continuing that. So, which is why we went with this. We tested a lot of scanners over the years, and we finally decided to, stick with one, which we felt that we'd be able to service better, and we also have a say, because, and we are also in the process of developing one ourselves. So that's also happening. So that's presently it. So we have some time. We have done an upper pre-preparation scan, okay, before we do the tooth preps. Okay, so, and next we're just going to do a prep scan. So you can just click and move from each setting to the other. Okay, so here, like we had for implants, we need to make a hole. So now this is going to be a full mouth. So I'm just going to cut most of it. Okay, so we got to start off from where we stopped. Switching on AI.
Good morning, all. Dr. George, can we move on to the question and answer session?
Oh, sure.